do that. That's just mean.
I mean, I can introduce myself. Hi, everyone. I'm Carlos Torres, OMS2. I was previous master's student and first year, so I've done this twice now. So hopefully I remember some stuff.
What's up, guys? My name is Austin. I am also a second year. I also did the master's with Carlos, and hopefully, I remember something as well.
Hi guys, I'm Cena. I'm a second year as well. I didn't do the masters with these three, but um, just here for the vibes. We'll see what happens.
I'm Ram. You guys know me from the last TA session, but I also did the masters and I will be here.
I guess I can give you guys some advice while we wait for like before we get at 7:05. Um, Definitely, if you guys didn't know, look at the speaker notes in the PowerPoints for discussions. They're really great. There's lots of explanations. Sometimes, like Costanzo doesn't explain something very well, but our professors go that extra effort to look at this, to write things in the speaker notes. It helps really explain things. So if you guys ever in doubt with the speaker
Sure.
notes, that they might have already explained it.
Yeah, thanks, Carlos. And also, did you guys get my TA review email or not yet? If anyone can answer that. I think it might be still pending, but hopefully it goes out by tonight or tomorrow morning. Um, Not yet. Okay. It was just getting approved through Dr. Jones today, so hopefully by tomorrow morning. But also check the speaker notes as well for that too. August 4th, that might have been the office hours one. Um, I sent out an email for the TA review and hopefully it should be out by tomorrow morning. It just needs to get approved. And all of our TAs put their hard work into it, so hopefully you guys can benefit from that as well. And it's 7:05 if you guys want to start.
Just share my screen here. Um, Okay. So you guys had a couple of objectives for this week. I may not be able to cover everything, but I can cover definitely things that I thought was like high yield. Um, Definitely what I recommend is know this chart, like just memorize it, try to understand it, because this will go a long way. Maybe not like even for this material, but even for like the following mods. Knowing the different concentrations in the ECF and ICF will go a long way. We had a question about the reflection coefficient.
Wait, Carlos, I'm sorry. Are you sharing your screen?
Yes.
We can't see anything.
It says loading, Carlos.
Well, can someone else share it?
Um, yeah, hold on. Do you want to try again? If not, I'll share it.
Sure.
Okay,
Can you
yeah,
guys see
that
it now? Okay. Man, we're gonna blame Horizon Wi-Fi for this. Okay. But anyways, somebody asked about the reflection coefficient. So the reflection coefficient is basically where like if you have an like a certain ion or a certain substance, it basically it depends on the permeability of that substance through the membrane. So some things like that are really big or like very high in like molecular weight, for example, like dextran or like albumin, it's going to have what's called a reflection coefficient of 1. So basically it'll try to cross and then it'll just bounce back. So if you have substances that are really stuck in one side of the membrane, basically what that's going to do is they'll have a lot of what's called like osmotic potential. So basically because of that weight, it'll draw in water from the other side, with the goal is to basically equalize the ion concentration on each side. So in these kind of scenarios, the reflection coefficient is either 1 or 0. That's it. There's nothing like in between. It's like there's no trick questions with that. Just be either 1 or 0. Some examples of where like for deflection coefficient is like 0 is like urea. So urea can like freely cross the membrane, and so because it can freely cross the membrane, it's basically it won't have an osmotic draw because it can always just move itself over to the other side, and it won't draw water with it. If you don't like the words, I also have a picture of it too. And why this is important is that it comes into the topic of osmosis. So the whole concept of osmosis is that water will follow where there's more solutes. So if you look at this picture here, like from picture A, there's more ions on the left side. And because of that, you'll notice that over time, water will flow over to the left side to kind of like equalize the osmolarity. If you guys have any questions at any time, please feel free to just unmute your mic and just stop me. So then I have a question for you guys. Can you guys see this? Probably.
We can send you guys the slides.
Yeah.
Right, Miram? Yeah.
Yeah, I was typing it in the
irritated. I have been in
Sahan. Yeah, okay. I'm gonna have Karan send this to your group me afterwards, but for now I'll answer the stuff in the chat so you guys can proceed. Carlos, you can proceed.
Yeah. Does anybody want to take a stab at this question? Or do you guys just want me to explain it?
They're all saying B. I don't know if you can see the chat.
Cool. Cool. Yeah, I got it. All right, let's see. Yeah, great job. So how do you guys approach this? What made you guys think it's going to shrink? Oh, well, I kind of put the explanation. I'm sorry. But you guys can read it and just let me know. Someone can say it.
So I'll take it. So it's the 150 times 3 is going to be 450 to the 280 times 2, which we're going to be and then ultimately it's going to go from the less salty to the water is going to go to more salt, which is going to be going to the going from the red blood cells to that more like salty place, and that's going to make it shrink.
Beautiful. Couldn't explain it any better. You're in good hands. You'll be good. Yeah, so basically because the solution of the calcium chloride has more osmolarity, it's going to drown the water. And then because of that, the RBC will lose its water and it'll basically shrink. So great job. And somebody was asking for some questions for the ECF, ICF drawings. So you guys may have seen this one, but what I would mention is know these pictures, but also be able to explain them even if there's no like drawings. I try to explain this like in your own words, because there could be a scenario where they might not show you the picture, but they're
Carlos, will you go to the last? I'm so sorry to jump in. Will you go to the last questions for them and explain it one more time? I know you can't see the chat.
Oh, sure. Yeah, so when it comes to this question, they're telling you that basically the red blood cell was calibrated at 280 milliosmoles. So basically the RBC has an osmolarity of 280. But then I'm telling you that I'm placing it in a solution of 150 millimoles per liter of calcium chloride. So what you want to keep in mind is that with these calcium chloride, it dissociates. So in total, you'll have 3 ions. So what you want to do is basically 3 ions times the 150 millimolars of liter. So that'll give you a total of 450. Now, when you compare that to the RBC, which is at 280, there's a big difference. So because the 450 has a higher osmolarity or higher molecules in it, it's going to pull water from that RBC into that 450 milliliter solution to kind of try to equilibrate the osmolarities between the two. So that's basically, because you're losing the water, that's going to make the RBC shrink. So that's a good question. So that's a good question. So like when it comes to the milliosmoles, I believe I already calculated it for you. I already did the calculation. Whereas with the solution of the millimolars, yeah. So for this one, for example, the 150, that hasn't been. So be very careful with the units. So for the milliosmoles, that's already calculated. Whereas with the 150 millimolars per liter calcium chloride 2, that hasn't been converted to milliosmoles. So you want to make sure the units match. So anyone else want to chime in? Thumbs up, thumbs down. Did that make sense?
I think you're good, Carlos.
Okay.
I think you're usually just going to work with liters. Correct me if I'm wrong or wrong.
It's mainly usually liters, but if they bring up milliliters, just in case, just know the conversion. But usually it's very straightforward. Oh, they might mix up the units. I would just say know your units just in case, just for conversion reasons.
Yeah, they're not going to make this too complicated as far as conversions go, because the professors understand that you guys have to study for other classes as well. So they want to make sure the math is simple, but they just want to know if you can do the thought process. They're not going to test. They're not going to try to get you on oh, those milliliters versus liters, and they're going to make it obvious.
Yeah, it's more so especially these math questions are more for you to understand the concept behind it rather than it's solely math. But know them just in case.
Mm-hmm. Okay, and then somebody was asked, we had a question about just having more practice questions. I believe there was a lot of questions in terms of these diagrams in the discussions and the supplementals. But what I would do to really maximize, your potential, your options here, is go through each of these little diagrams, and I want you to tell yourself, well, when would I have these kind of situations? Try to systematically tell yourself what would happen, and what kind of scenarios would I have this. Do you guys remember this question from from class? Does anybody want to answer this one? Nice. Great job. Does somebody want to explain why?
I can explain why, Mr. Carlos.
Yeah, please do.
Well, when an adult, not a pediatric patient, but specifically an adult that has diarrhea, they lose fluid. So the first compartment you lose fluid out of, so your volume, is your ECF. So that's why you will see the dotted line shrink in the ECF first before it equilibrates. However, the ions have not changed at this moment, so you won't see the dotted line go up or down.
Yeah, great, excellent. Great job. That was perfect. Yeah, so pretty much because we're only losing isotonic fluid, we're only losing fluid in the ECF, but we're not losing there's no change to the osmolarity. So really we're just losing fluid. Now, my question for you guys is, how would you treat this patient if we know they lost isotonic fluid? Yeah, exactly. Treat them with isotonic saline. And yeah, I like that, 0.9%. So definitely know the difference between like 0.9%, which is isotonic. If it's 0.45%, that's hypotonic. And if it's 3% normal saline, then it'll be hypertonic. So just be aware of those. And then just be able to identify these cover photos if it's described in like a text. Nice, great job. Nice. And then you guys already explained it. You guys already answered it. So just be on the lookout in case they have it as a word description. Am I missing anything? Let's see. Nice. And then you guys should have already seen this in class. But did anyone have any questions involving any of these scenarios? Like, I would really go out of like, take it step by step and try to explain every single scenario, because like we don't know what's on the exam, but they could potentially like just describe it to you in like in a question stem. That's a great question. So what would it look like if dextrose was used at a dextran? So when it comes to dextrose is just D-glucose, which is just glucose. So what you want to keep in mind is that when it comes to like the membrane, we have transporters on our membranes that actually helps us move glucose inside the cell. Whereas with like dextran, it has a really high molecular weight and it can't, so it's going to stay in the ECF. So we have a drawing here where, if you guys can see in this top image here, which is going to be for dextrose isotonic solution, here you can see that it's going to go into the ECF, but because we have transporters here in the membrane for glucose, it's going to cross the membrane and go into the ICF. So because there's now more glucose in the ICF, it has a higher osmolarity, and that's going to take water away from the ECF and into the ICF. And that's why you'll notice that you lose fluid here, but because you're losing solutes in ECF, that's also going to increase the osmolarity on that side. But basically you're seeing a shift to the left. Whereas if you compare it to dextran, the dextran can't cross this membrane, so it's going to stay in the ECF. So that's why you have the shift to the right when it comes to fluid and osmolarity. Hopefully that helps. We have kind of like a
I think it's more of a molecular weight rather than the reflection coefficient. Correct me if I'm wrong, Carlos.
What I know more about, like, I'm not really so much thinking about like the reflection coefficient, but more of in a sense that we have transporters on the membrane that can specifically carry over the glucose. But like you can't put like enzyme like kinetics, but like there's like a saturation to like the transporters. But basically, like, because you can get the glucose over to the ICF, it's going to increase osmolarity. They're not going to, I really doubt that they'll test it like that. They're going to make it like clear, like examples where like to do like dextran or something like where like, oh, someone has diarrhea. Like, what would that look like? They're not going to they're not going to try to trick you and use like glucose, because that one's more of like an exception because there's like the glucose transporters. You guys haven't really learned that yet. Hopefully that helps. That was a good question.
I just want to jump in while Carlos is taking a second.
Yeah, please.
There's a lot of TA reviews from past years you guys can do for practice questions. Unfortunately, we were limited to how many questions we can do for this year, but I think last year there's like 200 question TA reviews. So if you guys want to tackle those or extra questions, go ahead.
Yeah. Also, like keep in mind that there's probably going to be maybe like 3 to 4 questions just on this subject. So just like make sure you're really good at it. It's like really easy points. Like don't like put it off. Like trust.
Yeah.
Can I ask a question?
Yes.
I think she might be
Please.
talking about dextrose and dextran, one being permanent, the other not being permanent. Does that make sense or no? Or it goes back quickly or something?
Mm,
I'm not sure what you mean by permanent.
Or maybe you don't see the change because like, okay, never mind. I forgot it. Thanks.
Oh, it's okay. You can like explain more if you can
Yeah,
elaborate.
Mr. Zia, if you're a man, I'll explain it. So dextrose, you won't see a change. It's just sugar. It will be metabolized and broken down. So that's why the water will follow it, but the osmolarity won't change over time because it'll be broken down. Dextran, like Miss Merriam said, it is a large molecule. It won't be broken down. That's why it stops in the plasma. That's what Dr. K was trying to elaborate on.
Oh, okay. Thank you, Miss Abraham.
Thank you.
It was the difference mainly.
Yeah, that's fair. Thank you.
Yeah. The difference mainly is that dextrose can cross. So always think with these images. Sorry, Carlos, I'm just taking over.
Yeah, go for it.
If any question tells you, like, let's say you're losing isotonic fluid or you're adding or whatever you're adding, it's always going to go into the ECF first. And because dextrose can cross, it's going to go from the ECF to the ICF. So now when it's going to the ICF, this will increase the osmolarity in the ICF. Therefore, the water will end up shifting from ECF to ICF. And that's why you see a shift in the osmolarity where it goes higher and then it also goes more into the ECF. So always look at the ECF first. It goes into the ECF, then it crosses the plasma membrane into the ICF. That will increase the osmolarity, and water will follow the high osmolarity. But then when you see the dextran, because it's a large glucose, it cannot cross. So it's going to stay in the ECF. That will increase the osmolarity in the ECF. Therefore, the water will shift to the higher osmolarity from ICF to ECF. So you see a decrease in water in the ICF and an increase in the ECF. That's how I always break it down. Like I look at ECF first, osmolarity, then the water shifts to the higher osmolarity. And then if Carlos, you want to go back to the other images and then kind of go through them fast or something.
You put me on the spot. You got me help me to do like all 6.
Oh, sorry. If you want to, I mean, are you guys good with this? I spent a while on these last TA office hours, but if you guys need clarification on this, please say something now before we move on.
Yeah, is there anyone that like felt like one of these wasn't clear? You can like unmute yourself or. All right, going once.
Oh, she went over it today. Okay, perfect.
Oh, great. Awesome. Thank you. Okay, then we'll go to the next part. So I definitely want you guys to review the different transporters. Does anybody know what we mean by like primary active transport? Yeah, Samantha, go ahead.
Primary active transport would be something like the sodium potassium pump, where you're actively using ATP to pump things against their concentration gradient.
Yeah, excellent. Yeah, great. So yeah, definitely anything where you notice that's called like ATPase, that's you're automatically knowing that it's going to be using ATP and it's going to be trying to move ions against your concentration gradient. Does anybody want to explain the secondary active transport? Zayed, go ahead. You were first.
Secondary active transport is when it doesn't itself rely on ATP, but it relies on a gradient that was created using ATP, like for
excellent.
sodium. Yeah,
exactly. Great job. Excellent. Yeah, very much. So you're using the primary active transport, using like the sodium potassium pump to make a gradient, and then using that gradient to help bring in another molecule at the same time. So good job, you guys. I have no doubt in you guys for this part. So someone asked for a question. I'm using this from one of your clicker sessions, but I think it explains it pretty well. Does anybody want to answer this question? Okay, I can explain it. So if you look over here on the right side here, I know it's the thing circled, but you want to look here on the right first. You see here, this where it's converting ATP to ADP. So this is one of those sodium potassium ATPase. So we're using a primary active transport here to make a gradient. And then because of that gradient, now we can use this sodium glucose co-transporter here to bring in glucose into the cell. So this is what we can call a secondary active transport, because this transporter itself is not using ATP, but it's having to use like the sodium potassium ATPase to make the concentration difference. So my recommendation is I have these answer choices, but try to answer or like give a scenario for each one of these, because like the odds, like you want to play odds in your favor. So you want to be able to answer each of these scenarios, because it could be where like they don't ask you about primary active, they could instead ask you about secondary active transports. So I listed some examples here. These are just from the book. Any other questions in the chat? Cool. Okay, and then we had a question about the application of the Nernst equation. Austin, do you want to take this one, or do you want me to do it?
You can do it.
Okay. So with the Nernst equation, they're not going to ask you how to like calculate the membrane potential with like the whole equation, but they want you to understand if you can understand the concept of it. So in this scenario, I'm telling you guys that the membrane potential is minus 15 millivolts, and now I'm asking you guys, what is the direction? Where's the current going to be for the sodium? Do you guys think because it's very negative that the sodium want to go inside the cell to move it towards positive, or it's going to want to stay outside? Catherine, you're not going to need to know the Nernst equation itself, like how to like calculate it, but they want you to test the concepts, like the application of it. You won't have to calculate like the 2.3 over RT, that kind of stuff. You want to calculate that. Yeah, excellent. Great job. Does somebody want to explain? I mean, you guys got it, so I know you guys could explain it to me. Come on, 1, 2, 3, 4, 6 of you guys answered it. Yeah, exactly. So sodium will move into the cell to make it balance, basically try to bring it back to neutral, like basically to that positive. Yeah, and I always think of it like I try to like yeah, there's numbers, but I also try to think of it logically. That because the membrane is negative, opposites attract, and so it'll try to attract each other and try to bring it to positive. Yeah, exactly. Try to bring it to zero, more like try to bring it up to like the positive plus 65 millivolts, because that's where the sodium wants to be. But that's one way of thinking about it.
Oh, can I just say one thing, Carlos?
Mm-hmm.
Yeah, so they probably won't test you on calculations. However, you still need to know the formula. Like, I'm just like going through the book right here. There's like something called diffusion coefficient, and it's related to permeability. They could list like one of those parts of the formula and then have you say, oh, like if I increase the molecular radius, what happens to permeability? So you gotta know that it would decrease the coefficients, which is part of permeability. So like it's not like you could just skip over the equations. You do have to understand like what each thing does and how it affects something else overall. Just a heads up.
Great point, Austin. Let's see. Okay. Does that make sense to everybody? Can I get like a thumbs up, thumbs down? Okay, awesome. Okay. And then, and here's my explanation. And then try to keep in mind of the different equilibrium potentials. This will just help you in the long run. In case they give you, I mean, what will most likely happen is that they'll give you the equilibrium potential of each ion. But if you know it like ahead of time, that might also help. Okay. And then, does everyone know what like the voltage gated sodium channel does? Does anyone have any questions on it? Okay, I take it no, everyone understands it. So with the voltage gated sodium channel in the context of acetylcholine, we can get there. But can we talk about like an action potential first before we get to the context of acetylcholine? Yeah. Cool. So pretty much these voltage gated sodium channels respond to a change in member potential. So once you get that change in member potential, these channels will open. And in terms of for sodium, this will help trigger that like an action potential. What's kind of confusing and still not really explained well in like Costanzo. Also, I just gotta say, trust Costanzo, but like sometimes look at the speaker notes for the professors. They really help clarify things. So what can get tricky with the voltage gated sodium channel is that it has two parts to it. So it has like an activation gate and also an inactivation gate. With the activation gate, that's going to open fast. So that's why you'll get that flood of that's like sodium ions coming in. But then the inactivation gate has a little bit of a delay. So as you'll notice here on the bottom picture, this is where like the activation gate's open, but then the inactivation here closes. So that's where the ions can't flow through. And so that's where the picture of this comes in. So this is from Costanzo. There's a lot going on in this picture. I found a second picture that kind of explains like what's going on in each part of the action potential. But I would still like rely on this image from Costanzo. Does anybody have any questions about the action potential? Like, can somebody like go by like steps by step, like what happens at depolarization? What happens at repolarization, hyperpolarization? Does someone take a stab at it?
Yeah, I can try to explain it.
Yeah.
During depolarization, the activation channels open and the inactivation channels open, but the activation channels are only open for a very short period of time once saturation is reached, and then they close. And the inactivation channels are slower to close, and so they'll close during the repolarization period. And while they're closed, there cannot be like a refiring of the nerve. So that's where there's the difference between the relative refractory and the absolute refractory period in terms of refiring.
Great job. Yeah, exactly. So when you have your depolarization, you're going to have the influx of the voltage gated sodium channels will open, and you'll have that influx of sodium coming into the cell to make it more positive. And then you have that after that lag period, the inactivation gates will activate and then close the sodium channels. At this point here, you'll start getting at the peak, you'll get the voltage gated potassium channels to open, which will then cause the efflux of potassium out. So that's why as you're going over the hill here, you can start to do repolarization. And then as you're going down, because you're starting to repolarize, the inactivation gates start to open up little by little. But then you'll notice here that there's a bit of like an overshoot for the potassium channels, and that's why you have the hyperpolarization. At this point here, for the hyperpolarization, notice how it's a lot lower the membrane potential. So like theoretically, you can get an actual potential, but you need a higher stimulus. Same thing with like the relative refractory period, because now you're starting to repolarize. Some of the sodium activation gates start to open. So theoretically, you could also have an actual potential here, but you need like a higher stimulus because not all of the sodium channels are available yet. Hopefully that makes sense. Like, did anybody have any questions? But good job, Noah.
Could I also add to the hyperpolarization? It's also due to so like Carlos said, potassium leaking out through the leaky channels, and also another thing would be from chloride coming in as well.
Yeah, great job. So someone's asking, can you explain how it goes back to resting after hyperpolarization?
Oh, are you asking?
Popcorn. Yeah, popcorn.
Oh, me? Sorry, I wasn't paying attention. Isn't it due to the
Yeah, what I've read is like it's like the passive influx of sodium that helps kind of bring back to resting membrane potential. But in terms of like in general, it's more like the ions just kind of go back to equilibrium. I don't think they'll test you on that. I think they're like, that's like, it's a great question, but I don't think they're going to ask you that specifically. They're more interested about, what causes depolarization? Like, why can't you get a active potential in an absolute refractory period versus relative? That's a great question. Yeah, so sodium channels, leaky channels.
I think they're more going to be like, oh, why is the resting membrane potential around like -70? And then what would that answer be? If someone wants to answer that. Yeah, Ziad.
Because the permeability at the resting membrane or at that rest, potassium is more permeable to the or the membrane is more permeable to potassium, and potassium's equilibrium potential is like -90, so it'll be more close to that instead of sodium's, which is like +65, but it's more impermeable to sodium, so it'll be closer to potassium's.
Yeah, there you go. That's
Good
true.
job.
Good job. And also, like, it's gonna be also due to the leakiness, the leaky channels. So they usually like to use that leaky potassium channel. That's why. That's another reason why.
So someone asked about the difference between the absolute and relative refractory period. So it's a great question. So when it comes to like the absolute refractory period, this is where you get an active potential. But at this point, like anywhere here, if you get one active potential, you can't get a second active potential because of the sodium activation gates. They're still closed. So even if you try to use more stimulus, it's not going to open because you're still waiting for the sodium activation gates to open. Whereas in the relative refractory period, not only do you have the increased conductance of potassium leaking out, but you also have the partial opening of the sodium inactivation gates. So by that point in the relative period, theoretically, because some of the gates are starting to open for the sodium inactivation gates, you can get a action potential. Hopefully that made sense. Hope so.
I don't know what else like the chloride channel is important, Carlos? Just in terms of GABA and glycine, right?
Probably. Yeah. And then if they ask about you in excitatory, then think about that the excited, like the ESPs will increase sodium conduction. Yep. Hopefully that helps. If not, there's a second diagram to help kind of like, so what I would recommend is kind of like just cover up each spot, like each tag here, and like test yourself. See if you can remember like, oh, what happens to depolarization? What happens to repolarization? What happens to hyperpolarization? And just really test yourself there. Cool. And then here I go. Actually, I kind of explained if none of my words made sense, then I have it here, so you guys can go back to it. I also put notes in the speaker notes, so I took the explanations from the supplemental sessions from Dr. Carr, and I also included the explanations from Costanzo, if that helps. All right, Austin, you're up.
All right. It is 7:43, so I'm just going to run through this really quick, and then I'll just explain what to expect on the exam. So basically, one of the questions was like, name the drugs that can exclusively block the sodium channels. How does it work? One of them could be tetrodotoxin or lidocaine. Now then, and basically no action potential is going to be produced because we can't get sodium to depolarize. For the test itself, one of the questions that I remembered was that a man came in after trying the puffer fish, and he I don't know, he was feeling ill. What most likely, what toxin was most likely found in his system? And then the answer was tetrodotoxin. So that's like right out of the book. Another one could be if you want to numb the area for a suture, what would you use? Lidocaine. And then when it came to potassium channels, they actually said, I remember from one of the questions, the patient came in and they realized that the potassium channel was blocked. What toxin it was do you expect to find? So, and that was like TEA. So just keep in mind of like, and that all that stuff was like straight word for word right out of the book. So just keep in mind for the toxins.
And then I believe they mentioned that like lidocaine itself targets the voltage-gated sodium channels. So then that's why you don't get an action potential, because lidocaine targets that specific channel. So that's why when you get like a dental procedure, you don't feel pain, because it targets that action potential.
Yes. All right. Any questions? Okay, we should go to the next slide. I do want to leave time for them to ask us questions as well. So and then we could share.
Can I add to that real quick? They might give you like the action potential drawing, and then they'll be like basically what Austin just explained, and you have to like point where it's gonna get blocked, and you got to know where the sodium channels are located. Okay, continue.
All right. What are the factors that can decrease speed of conduction in a neuron? How is conduction impacted on the neurons which have lost the myelin sheath? Name the disease and symptoms. All right. The two most popular ones from when I read from Costanza was definitely the smaller diameter and demyelination. You guys will come to realize very, very soon that whatever improves something, they're just going to flip the word and it's just going to decrease it. So just keep in mind like if you increase the fiber size, it's probably going to go faster. If you decrease the fiber size, it's going to go slower. So just try to be on the lookout. Another question was name a disease and the symptoms. The only thing I could really think of is probably multiple sclerosis. But if they don't talk about it in the book, do not worry about it. Like, they won't try to trick you. If it was, the tests will say this patient has multiple sclerosis, and the speed of the conduction of the neuron is slowing down. Why is it? And then they'll give you like less myelination would be like probably the answer, or smaller diameter of the fiber size. It'll be like one of those two. Don't try to don't try to like think outside the box. On this one, they'll pretty much give you most of the stem, just as long as you stick to the book. Any questions? Okay, we could go to the next. Go to the next slide. All right. Are there increased numbers of voltage gated sodium channels at the nodes of Ranvier, and how this number helped the conduction? So there is an increase of voltage gated sodium channels at the nodes. So when I think of myelination, it's like kind of like a I gotta say this. All right. So active potential, if it's by itself unmyelinated, it's going to shoot everywhere. But if it's myelinated, it's going to insulate it to where there's only like one pathway. And then that's why it goes directly to the next node. And then at that node, there's a bunch of sodium channels. That means that will lead to a bunch of action potentials a lot faster. So that's why myelin is important, because it gives it direction and then goes off to the next spot and the next spot and the next spot. You know what? Yes, thank you. You want to take the internal pathway, right? Internal pathway? What does that mean? Like, do you guys know what that means?
No, could you like explain what you mean by internal?
I talked about it talked about it in the textbook. Yeah, so like when they say like less resistance, that's what I meant by like the myelination kind of insulated, and it only gives it one path, and that's the path of least resistance to the next node. So that's like the whole point of it. Yes. Yeah. Yes. Thank you, Jay. Jay. Listen, everyone listen to Jay. All right.
Next slide.
Okay. Yeah. Yeah. Next slide. Can you explain hyperkalemia cause of that? If hyperkalemia causes X potential to occur, or just depolarization? Okay, so this like question is it was very hard for me to decipher, because if you get, so our resting membrane potential inside the cell is -70. So if we get hyperkalemia, we're basically saying potassium's leaving. That means if we have less potassium inside the cell, it's going to slightly depolarize, but it won't reach the threshold to send an actual potential unless we get sodium inside it. Okay, so it kind of depends. However, if the stem of the question says we have a patient with prolonged hyperkalemia, so he's had hyperkalemia the whole time, the action potential won't be able to repolarize properly, and then the inactivation gates won't be able to open. So then no action potential will be able to fire off. So I really hope that makes sense. All right, I am confused. Okay.
So the way I kind of describe it is where with hyperkalemia, that means you have more potassium in the ECF than normal. So if there's more ECF, like more potassium in the ECF than normal, think about what that would do to your normal concentration gradient inside the cell. But normally, if you look at that's why I have this here. That's why if you memorize this will help a lot.
Yeah.
But if you look at this chart here, where normally it's like potassium is 120 inside the cell versus 4 in the ECF. If this for like say like hyperkalemia, where now if this is 8, that drive for potassium will now be decreased. So that means you're going to retain more potassium inside the cell. And so because you're retaining more potassium inside the cell, that's going to make the resting membrane potential more positive, which then what would happen? Because you now increase the membrane potential, you could initially have a depolarization. But then the problem is like how Austin mentioned, that with once you get depolarization, because you now have more potassium out in the ECF, that drive that we initially have to get repolarization is going to be a lot slower. So it's going to make it a lot more difficult to actually repolarize the cell. And that's why when you have patients like in cardiac who are having like hyperkalemia, it's they always like to reference like the heart. So because you can't get back to like normal, and a lot harder, that's going to lead to arrhythmias, and that's where potentially a patient could potentially die because you're not being able to repolarize that as quickly. Hopefully that makes sense, but that's where knowing this, it's really helpful because then you actually can apply it to the situation.
Yes, please memorize that chart. Please memorize that chart.
They have a good explanation in the discussions about it because it's just a complicated topic to really think about. I know they have a picture of it on Costanza, but if you look in the discussions for your class slides, they explain it pretty well.
There will be a question like this. 100%. This is a very high yield topic. There will be a question on hyperkalemia. What is
Either
membrane
hyper
potential?
or hypo, one of the two. Sorry, Austin, I hate to jump in, but
Yeah,
there's definitely going to be a question on it.
yeah, it's a very high yield. What is membrane potential versus equilibrium potential's relationship? Okay, so membrane potential is the voltage of the cell at any given moment. Let's just say resting membrane potential is just negative 70, which accounts for all the different ions, and then equilibrium potential is the voltage of the individual ion. So like when you go back to the chart, there's sodium, there's potassium, there's chloride, there's all these different ones, and they all have a equilibrium potential where they prefer to be at. That's why it's really important to memorize that like potassium's at negative 85, there's sodium at like positive 120. I think chloride's negative 80 or something like that. But like when you use that for the nurse equation, so that's like the difference between the two. Do any of you guys want to explain hypokalemia?
Yeah, so we can. Yeah, so look at the table again. We'll just flip this around. So instead of the potassium being like +8, we'll say it's like 2 or 1. So what do you guys think that will do to the drive of potassium? Think about it like there's 120 in the ICF, and now we'll say the ECF now has 2. What do you guys think that'll do to the concentration? Yeah, it'll increase. So you'll have more potassium. Exactly. So more potassium will leave the cell through, like, for example, like the leaky potassium channels. And so what do you guys think that'll do to the resting membrane potential? Will it increase or decrease because you have cations leaving? Yeah, so pretty much like, exactly. So it'll be more negative inside the cell. So do you guys think with a normal stimulus will be easier or harder to get a depolarization now that the membrane's more negative? Yeah, it's going to be harder. Correct. Alex, does that make sense why it's going to be harder? Because, for example, if I go to the drawing here, when you look at the resting membrane potential, because there's more potassium leaving, because there's more motivation through the leaky channels, instead of being like -70, the resting membrane potential would be like at -85. So that's going to make it harder for like a normal stimulus to get it to depolarize. Hopefully that makes sense. Okay, awesome.
And then there's a question between hydrostatic versus oncotic pressure. The way I see it is hydrostatic is basically when fluid is going to get pushed outside of the capillary, and then oncotic pressure is when fluid gets pulled in, and then that's basically because of of proteins or albumin or anything like that. Yes, it's very important to know the difference between the two because this basically is going to explain how fluid gets transferred from ICF to ECF. So please know the difference. And like when you guys are studying this, think about, if I increase oncotic pressure, where's the fluid going to be? Or if I decrease hydrostatic pressure, where would the fluid go? So yeah, I just made a quick little image. Yeah.
And this concept is going to follow you guys. So definitely this will be covered in cardio when you get to your cardio mod. So learn this now and it'll make it easier to follow when you guys do the cardio mod.
Yes. Oh yeah. So when you're learning the steps of how ACH is released, there was a question about ACH. Acetylcholine. My bad. We'll go over it real quick, but just know where it gets released and what each toxin does to the neuromuscular junction. So for this one, like for this question right here, it's false because acetylcholine comes out of the presynaptic terminals, not the post. And then also this toxin prevents acetylcholine vesicles to be formed completely, and then it doesn't get released at all. And yeah, it bottles it up. And I think curare competes with it. I think. Do we need this toxin? Yes, you do. There's 4 that you need to know. This is one. There's a chart in the book.
So they could potentially ask you about botulism, but it's like pretty Botox. It's like Botox. So think about it. That's pretty, like, everyone likes Botox. Everyone wants to prevent their wrinkles. Sounds pretty relevant. They could test you on like acetylcholinesterase. So they'll mention like neostigmine.
Yes.
Know about the hemojulineum and the curare. So know those different scenarios for sure.
Yes, those 4, definitely. And then you go to the last slide. Acetylcholinesterase inhibitors can be used for myasthenia gravis. What are the symptoms of the disease and the maintenance for treatment? Okay, so this is going to be like this. You have to break it down pretty first. So first, myasthenia gravis is when the body produces antibodies onto the acetylcholine receptor. So let's see here. Let me think. Should we go through the steps first, or should we just?
I think maybe go through it really fast so that they understand where you're coming from.
Okay, so the neuromuscular junction is basically from the neurons to the muscle. All right, and I think there's like 5 steps, so I'll try to go brief. The first step, I think acetylcholine gets created, and then I think the second step is when calcium comes inside on the presynaptic cleft, and then that allows like the vesicles to form with acetylcholine. When calcium gets uptake, it releases the acetylcholine into the cleft, I think, the cleft. Acetylcholine then binds to a receptor on the muscle, which then allows sodium in and potassium out, and that causes a depolarization of a plate. It's not a depolarization, but it's like a series of depolarizations, and then that sends off an action potential to the muscle. So then, when acetylcholine binds to the receptor, there's acetylcholinesterase that breaks it down, and then that gets reuptaken back into the presynaptic. I forgot what it gets broken down into actually, but so for this, myasthenia gravis competes or produces antibodies that competes onto the acetylcholine receptors. So because of that, acetylcholine, there's no depolarization onto the muscle. All right. So then why does acetylcholinesterase can be used for myasthenia gravis? Acetylcholinesterase original job is to break down acetylcholine. All right. So we inhibit the breakdown of acetylcholine. We have the acetylcholine kind of just stays in the cleft. And as long as it stays in the cleft, the more likelihood that a action potential or like a depolarization will happen, and then that's why it will work. All right, so as long as we prevent the breakdown of acetylcholine, it should be fine. When like in the book, there's like these purple boxes that kind of gives you a case report. Please read those. Those are very important. They'll give you a breakdown of everything and 100% explain it a lot better than I do. I really hope that was clear.
I just added hyperkalemia. If someone wants to check if that's correct. right? I think. No, I think the hyperkalemia. Oh, actually, I don't know about hypo.
I think that's more like out of scope. Like they're not going to ask you that. I mean, it's a great question, but I don't think that's like within the scope of like foundations. But it could be like for MSK. Like you could definitely bring it up to Dr. Carr and Dr. Shah when it comes to muscle weakness.
All right. Are there any other questions regarding the exam or any tips that you guys want from us? Because it is 8 o'clock. I understand that we all have like other classes. Yeah.
And these slides will be provided. So you guys can always refer back to these, and I put some extra details into speaker notes.
What time is this?
Well, I don't know what time.
I don't know.
I don't know what time. So tips, memorize the